Dr. Woodland here. Today I want to share with you my story of having sleep apnea as a child, and the hope is that in so doing we can become more aware together of sleep apnea, how it works, how treatment of it works, and how we can best advocate for our own needs as patients. So let's become more aware together. So, my story begins early on in childhood. As long as I can remember, I've always been a snorer. And my parents could tell you that this was a source of consternation for them, that I was this loud snorer. It came out that later on here and there, that my parents would notice me stop breathing in my sleep. But the loud snoring, and I mean really loud, this was something that was a concern. And as I grew in childhood, it was something that was, I think, quite embarrassing. I would often be told if I'd go to the random birthday party overnight, and often I was told, oh, you were snoring all night. We had to put you in a separate room because you were keeping all the other kids awake. And it became this source of anxiety and embarrassment for me as a kid, to the point where I started to avoid campouts and scouts. I started to avoid other outings and sleepovers and things for fear that I was going to give someone a bad experience. And I remember even one time in summer camp that as a teenager at this point, I took some earplugs with me because I knew that some other people might need them. Now, some other kids were heavy sleepers and didn't seem to care as much. Other kids were really lighter sleepers and really seemed to care about it. And I remember taking earplugs, and one kid, just like, I was up all night, and he was snoring or whatever, and I remember telling him, I've got some earplugs you can use. He's like, you better give me those earplugs, type of thing. And all of this is this source of anxiety for me. And my parents, they would encourage me to want to to get it fixed, but they knew probably that, and I knew that probably meant getting some sort of surgery, and I didn't want to do it. I was so afraid, and my parents didn't force it upon me, but it wasn't until I was 18 and about to go to college, that my mom, I remember, we always had important conversations driving somewhere, it seemed like. And I think we were driving, to go to the store, and she said, Sean, you need to get this fixed in order for you to go to college and to have roommates, and to do that. And so finally, I guess I relented as well, and I said, okay, I'm old enough now to figure this out. And so the process for me I was about 17 at the time. The process for me was I went with my mom, and we went to an ENT, so ear, nose, and throat doctor. The doctor, I remember he had one of those big kind of mirror things, right? And he was looking at my throat, and he saw what I saw most every day, which was that my tonsils were huge, and I mean huge. They almost completely filled the back of my mouth. And so he's like, yep, these gotta go. These have got to go. And so he decided that they would remove my tonsils and my adenoids. And I had kind of expected that to happen. I had heard about other people who had gotten that done. But then the other curveball that he threw me was, now we also want to remove your uvula. For those of you who don't know, the uvula is that little thing that hangs down at the bottom of or the top of your throat, and we want to cut that off. And so I said, okay, okay, and so that's what had happened. Now, thinking about why my tonsils had gotten so big. So as a kid, I often had colds, and I was getting sick. Now it's hard to say, well, which happened first, the tonsils getting big and no longer working properly, and then you're getting more colds, or the colds kind of creating that inflammation in the tonsils and then permanently becoming inflamed. It's kind of hard to say what preceded what, but ultimately, I sometimes called myself a sickly child. I was getting colds as a kid, like every month, just cold after cold after cold, or at least that's how I remember it. And so we decided to get the tonsils out, the adenoids and my uvula as well. Funny enough, I'm aware now that getting all three of those removed is not typical these days for pediatric patients. Maybe the closest thing that's done these days is called a UPPP. And that said, this is what we were doing. We wanted to clear the airway out as much as possible. And so a few months passed, and then it was time for surgery. We decided to do surgery pretty much first thing after I got out of high school. So after I graduated, so that I could take some time to not be in school and recover. And so the surgery itself was not long, right? So it took probably about an hour or so to do the surgery. And then after that, it was on to the recovery room. And I was generally anesthetized, right? So I'd been put to sleep. And then I was waking up in the recovery room, and I could tell that I could feel pain. And they are asking me, are you in pain? Are you in pain? Where's your pain level? And I remember often being like 8, 9, right? And so they kept on giving me pain meds. So I remember I ended up getting like 2 shots of morphine and like 13 shots of, I think, Demerol is what it was called. And so they were just making sure that I was comfortable as I was in the recovery room for maybe an hour or 2 afterward. Now, one funny story is that, so there was a nurse there, and she was helping me to kind of get dressed, helping me to get into the wheelchair so that they could wheel me out and so that I could go home after the surgery. And I remember as an 18-year-old that I decided to play a trick on her. And so she was, I guess she must have been very concerned about my safety and about me falling. And so I got off of the bed in the recovery room, and I could see she was there waiting for me to go into the wheelchair. I believe the surgeon at that point was also there, and I decided to fake a fall. I kind of did one of these stumble things, and her jaw dropped for a second. And then me not being able to talk because I just had my tonsils out, I just kind of did a little wink at her. And then I remember the surgeon made some comment about how I was just some typical teenage boy doing that sort of thing. So then recovery happened, and I remember I was given Tylenol with codeine, and there was a time at the beginning where I got a little bit of headaches from the codeine. My mom pointed out that she thought I had a hangover from the codeine. But over a couple of weeks, I started to get better. I actually lost about 10 to 15 pounds over the course of those 2 weeks because I was just eating, you know, popsicles basically and ice cream, and not eating much else. And I didn't have a taste for a whole lot of things, and so wasn't eating a whole lot. But yeah, so that was kind of my story. Interestingly enough, after recovery, I believe in part because of the losing the uvula, I actually had to relearn how to drink fluids, in particular when my head was tilted down. For example, drinking out of a water fountain or a drinking fountain, the water would basically go right up through and out my nose, and so I kind of had to learn how to do that again. My voice changed a little bit as well, not significantly, but it was this thing where I sounded less congested, right? I sounded like more clear because there was less back there. Okay. So now I want to talk about how things typically work today. Now, for those who, if there's a concern for sleep apnea, typically you go through your primary care provider. And I wasn't aware of this step as a kid for me, though I'm pretty sure my mom talked to our primary doctor first and got a referral. Now, if there's concern for sleep apnea, you typically will get sent to a sleep medicine department, and they're in charge of testing for sleep apnea. And for adults, the way that typically works is that there's a home sleep test where you have a smartwatch that's kind of hooked to a lead with a finger monitor, and you wear it overnight at home. And that is a kind of a quick and dirty way to test whether you have apneas that are going on. And if it's conclusive, then from then on they'll move to treatment. If it's not conclusive and they have reason to bring you in, then they will bring you in for a PSG or a polysomnogram. Now, for kiddos, typically bringing you in for a PSG is the first way to go, as most kids have a hard time, and particularly younger kids have a hard time with a home sleep test, keeping it on and getting conclusive results. Now, for kids, for treatment, still tonsillectomy, adenoidectomy is a preferred method of treating for sleep apnea. Now, so let's fast forward and say, okay, maybe you've tried CPAP and or APAP or BiPAP, and it's not going right for you. It's not working. Now, there's a couple of reasons that this can be the case. First reason is mechanical. The second reason is psychological. So first, mechanical. So it could be that the pressures are off. It could be some other settings are off. Could be that the mask is an issue, or the hose is an issue. Logistically, depending on if you're a side sleeper, a stomach sleeper, or a back sleeper, these can all be things that can logistically and mechanically be obstacles to using PAP therapy. From a psychological standpoint, typically it's related to anxiety. Okay, anxiety around having something on your face, claustrophobia, feeling like you're not being able to get a breath in, and that causes a fear response. To a certain extent as well, motivation is also something that comes into play from a psychological standpoint. Now, people often will seek alternatives to PAP. Now, PAP is the gold standard, right? It is the thing that works the best for sleep apnea. That said, people are often looking for something else because they don't want to do it, right? And probably the most popular alternative today is HGNS, also known as hypoglossal nerve stimulation, okay? Hypoglossal nerve stimulation. That's a lot to say, but let's talk about that. So, what is What is hypoglossal nerve stimulation? Okay, So what this is, typically, it's an inserted device. Maybe you've seen commercials, for example, for Inspire. It's the most popular hypoglossal nerve stimulator out there. And what it is, it's an inserted, kind of like a pacemaker, right? So there's this battery that's got a lead that goes to your hypoglossal nerve, and it stimulates that nerve and opens up your airway when you're sleeping. It requires the user to turn it on or off. So you're signaling to the machine or to the device that it's time to sleep. Okay. It doesn't make you sleep, but when you lie down to sleep, then you have there's a little fob thing that you press, and it turns it on and it opens up your airway. Now, how do you qualify for getting the Inspire device or for getting hypoglossal nerve stimulation? A lot of patients these days want to know this, right? How do I do this? Because the commercials show that it is something that works really well. It's something that is really not labor intensive at all, and it's something that helps me sleep better. So how do I qualify for it? Now, sleep medicine departments and head and neck departments, they use what's called the STAR criteria. So the STAR criteria for HGNS. Okay, so what are the STAR criteria? The STAR criteria are, first of all, you have to have obstructive sleep apnea, and you also have to be intolerant to PAP. Okay, so this is an important piece. So you have to have tried PAP and not work for you. Okay, you do not qualify if you have a BMI typically over 32. I've seen 35 as well, but thereabouts. And then your AHI has to be between 20 and 50. So what's BMI? So BMI is body mass index, okay? So it's basically the ratio of your weight to your height, okay? AHI is the apnea-hypopnea index. So this is the kind of the tried and true measure of sleep apnea severity, okay? So if you have sleep apnea AHI and it's under 5, that's typically normal. 5 to about 15, and again, this is an adult, so 5 to 15 is mild sleep apnea, and then typically 15 to 30 is moderate sleep apnea, and then anything 30 and above is severe sleep apnea. What the AHI measures is it measures the amount of times that you either completely stop breathing, which would be apnea, or partially stop breathing, which would be hypopnea, okay? And it adds it together, and it's the number of events that happen per hour, okay? And so if you have less than 20 events per hour, you don't qualify for HGNS, okay? If you have more than 50 events per hour, you don't qualify for HGNS, typically speaking. Another exclusion criterion, I'm looking at central apneas, which are a little bit different than obstructive apneas. Central apneas come from the brain and how the brain is telling your airway to open up. And also mixed apneas. If that index is greater than a quarter of your overall AHI when you do a sleep study, then that also is exclusionary for hypoglossal nerve stimulation. The idea there is that the Inspire device or the nerve stimulator, it's stimulating your nerve downstream from your brain activity, right? And so if your brain is telling your airway not to open up here and there, then the Inspire device is not going to catch on to that, right? It's just going to catch on to how it's going in terms of, is there an obstruction that is producing that difficulty breathing? Now, an added consideration for determining whether you would qualify for HGNS is the DISE. So what's a DISE? What does that stand for? So it's drug-induced sleep endoscopy. drug-induced sleep endoscopy. What this is you go to the doctor's office and they put you to sleep, they make you sleep, and they then put an endoscope, so they put a camera up through your nose, and then they look at your breathing while you're sleeping, okay? And the reason being is that if your airway is collapsing in certain ways, then that would also be a contraindication for the Inspire or for HGNS. Specifically, the most problematic way is what they call complete concentric collapse, which basically means that your soft palate and your side walls of your airway are all kind of closing in on each other when you're sleeping, okay? And that wakes you up and your airway opens up and then it closes in kind of like that again, okay? That would be a contraindication for HGNS. So what is my take as a sleep psychologist who's also had sleep apnea on this issue, okay? Now, obstructive sleep apnea is important to treat. With untreated sleep apnea, you have increased risk of stroke, hypertension, heart disease, heart attack. You have increased risk of depression, also increased risk of diabetes when your sleep apnea is not treated, okay? So it's also important to note that CPAP is still the gold standard for obstructive sleep apnea. That said, adherence to CPAP is notoriously difficult. And while HGNS, hypoglossal nerve stimulation, the Inspire device, if you will, while it can make things simpler for many, the band for success is actually fairly narrow, right? Thinking of those contraindications, right? The things that have to go right. Also, you kind of have to be in charge of it, right? The band for success is fairly narrow. Now, in the medical sphere, the STAR criteria implicitly communicate to patients that intolerance to CPAP is a static factor, meaning unchanging, right? That said, as a sleep psychologist, I'm here to tell you that that is not the case, right? That is not the case. And really, CPAP intolerance at its core has to do with anxiety. So let me explain what that means, right? So when we use the CPAP and it creates this anxiety and we don't use it, what happens is that our anxiety increases as we avoid using the CPAP, okay? And so the less that we use it when we've had a negative experience, the more anxious we become upon trying to use it or thinking about using it. One way that we can get through this and actually still use the gold standard treatment for sleep apnea and overcome our anxiety is what's called CPAP desensitization. So what is CPAP desensitization? Well, what this is a fairly straightforward list of steps that basically you start by having the CPAP there with you, and you start by putting on the mask not hooked up to the machine, and you just wear it for an hour a day, and you do that until you don't feel anxious. And then you stepwise go further into using it. And the idea is that if you can do the next step without anxiety, then you progress to the next until you are sleeping fully in the night with the CPAP, okay? It actually works. It works for folks. Oftentimes, it takes motivation, it takes support from a sleep psychologist such as me or some other healthcare practitioner who specializes in getting people on CPAP, but it actually does work, and people can find that they are able to increase their adherence to CPAP. So to conclude, my story with obstructive sleep apnea is ongoing. It started as a small child, and I'm really grateful that I get the opportunity to work with people on their sleep apnea today as a sleep psychologist. I gain a lot of I gain a lot of meaning out of supporting people to overcome something that I also struggled with as a kid. And as a former patient and current doctor and advocate for the mind-body connection, it's my hope that this has been of benefit to you, and that you share this with someone who maybe might also benefit from my words. I hope that you have a good day, and encourage you to like, comment, subscribe. In particular, I'd love to hear from you if there's anything that you feel like I got wrong in today's video, or if there's anything else that you'd like to hear from me, or any concerns or questions I can address. I'm here for you. Hope that you have a great day.